So thank you all for inviting me to talk about management of uterine sarcomas from a surgeon's perspective. I do surgery and chemotherapy, so I'll talk a little bit about chemotherapy as well. So, uterine sarcomas represent only about 7% of all uterine cancers that we treat in the United States. Incidence is still quite low in the US, about 7 per 100,000. And luckily, a lot of times these cancers are caught at stage 1. So these are incidental findings such as uterine leiomyosarcoma and endometrial stromal sarcoma because they're incidental findings that are found at the time of hysterectomy. The key to surgical management for these tumors is, if you suspect extrauterine disease, is to optimally cytoreduce these patients. These are not tumors that generally spread via the lymphatic system. These are generally spread by direct extension. So usually you'll find if they are extrauterine, they'll be as masses in the abdomen or pelvis. Lymphatic staging is generally not recommended, particularly for uterine leiomyosarcoma, which is the most common of these. We do tend to do them for carcinosarcomas, but as our pathologists will concede, these are likely being and generally thought of as not really sarcomas, but poorly differentiated endometrial cancers. So globally, we put these into 3 categories: the good, the bad, and the ugly. Low-grade endometrial stromal sarcomas, as our pathology colleague just said, are generally very hormonally responsive, as are adenosarcomas. Again, optimal surgical cytoreduction is going to be the key in these cases. Uterine leiomyosarcomas in even stage 1 tend to have a very poor prognosis, as are carcinosarcomas, even though we don't really consider those as part of the sarcoma family anymore. And the really bad ones are the adenosarcomas with sarcomatous overgrowth and the undifferentiated sarcomas or high-grade ESS. Again, this is the FIGO 2009 staging, where we went kind of back to more looking at the size of the tumor. This is fairly prognostic. We do know that large tumors tend to have a poor prognosis, even if they are confined to the uterus. This is likely because of some degree of lymphatic or direct extension. So the first case that I'll present is a 52-year-old woman that had an incidental uterine mass on ultrasound, postmenopausal bleeding, which is a very common sign or symptom of sarcomas of the uterus, abdominal pain with abdominal distension, and sometimes these do occur perimenopausally. The specimen was removed and was found to be an endometrial stromal sarcoma. So endometrial stromal sarcomas, most are stage 1 because they are incidental findings at the time of hysterectomy. You do get some that are advanced stage, and again, the surgical technique here is to get optimal cytoreduction and to get all the tumors out, particularly if they're low-grade stromal sarcomas. What are some of the prognostic factors for patients that are diagnosed with an ESS? Again, age. Older patients tend to do poorly. Race, these tend to be a little bit more common in the African-American population in the United States. Optimal cytoreduction is protective, and obviously stage and grade are going to be your 2 biggest prognostic implications for ESS. This is a very hormonally sensitive disease. You absolutely want to get ER/PR staging on these. These are mostly ER positive, and globally for endometrial stromal sarcomas, particularly for the low grades, we tend to either recommend observation or anti-estrogen therapy with letrozole. The anti-estrogen therapy is really what is kind of driving a lot of this now. We can use letrozole or other anti-estrogen agents simply because these tend to be very, very hormonally sensitive tumors, even in patients that are low grade. The thing to remember is we really do want to remove the ovaries in these patients. If you do an incidental hysterectomy without removal of the ovaries, we do recommend generally to go back and remove the ovaries if they've been left in from a surgical perspective, simply because we know that, again, these are very hormonally sensitive. What hormonal therapies can you use? You can use aromatase inhibitors. GnRH analogs are not as commonly used. It's mainly the aromatase inhibitors. You can use anti-estrogens such as megestrol. I don't think medroxyprogesterone acetate would be strong enough progesterone to use, but in general, you could use anti-estrogen therapy, including Megase. Again, in the use of adjuvant progestins in these patients, really in patients that don't get them, they have a fairly high recurrence rate. Again, it's a small study in 2003, but again, because these are such rare tumors, this is mainly what we have. Again, should you use, this is a big question that we ask our patients and our patients ask us is, should we be using estrogen therapy to manage menopausal symptoms, particularly in women in their 40s and 50s who get an endometrial stromal sarcoma? The reality is the answer is a no. We probably should not be using estrogen replacement therapy, certainly not systemic estrogen replacement therapies. Again, these are really, really hormonally sensitive tumors, and we want to shut off that estrogen axis as best as we can. Again, undifferentiated sarcomas, just briefly, formerly high-grade ESS, again, very rare, but very poor prognosis. Optimal cytoreduction is really what you should be going for from the surgeon's perspective. So again, 15 minutes is a short amount of time, so I'm going to try to respect and talk about kind of the most common of the sarcomas that we're going to see, which are the uterine leiomyosarcomas. Again, your classic presentation on a patient with a uterine leiomyosarcoma is going to be a perimenopausal woman who presents with an enlarging uterus. They've looked at this pretty extensively. That kind of rapidly enlarging uterus symptom is not as common as we think it is, but in any patient that does have a uterus, particularly patients that are postmenopausal, that is growing largely, we have to think about this in the differential. Pathologic review is essential, as the speaker before me said, getting the correct diagnosis, and really we use the Bell criteria for this. Coagulated tumor necrosis, number of mitotic figures are really the things that are going to drive the prognosis from the pathologic point of view. What are prognostic factors in patients with uterine leiomyosarcoma? They're very similar to all of the other cancers we treat in GYN oncology. Again, age and race, these tend to occur in the United States in African-American patients. Optimal cytoreductive surgery is going to be protective. We want to resect all of the tumor in these patients. Again, most of these tend to be uterine confined, and once they leave the uterus, they're very difficult to treat, and obviously stage and grade. 3 graphs here looking at this in terms of survival. Unfortunately, these do tend to occur in African-American patients a little bit more than expected. And again, lymphatic spread is unlikely, so we generally do not recommend lymphadenectomy in patients with leiomyosarcoma, though we do tend to recommend removal of the ovaries. Not quite as hormonally sensitive as an ESS, but still many are ER positive. So what about adjuvant treatment? Doxorubicin is now really pushing. We kind of thought of it as a standard of care for sarcomas of the uterus. It fell out of favor, and now it's kind of coming and making a comeback. So I'll go on to the next slide. So everybody's familiar with GOG 277. This was a very interesting study that was opened looking at gemcitabine and docetaxel. GOG 77 from Dr. Hensley out at Memorial Sloan Kettering really did establish the treatment of of leiomyosarcoma in the adjuvant setting with gemdosi. This study wanted to take stage 1 leiomyosarcomas after they had had hysterectomy and randomize them to gemdosi followed by doxorubicin versus observation. Unfortunately, this was a very interesting study, didn't quite pan out as best as we thought. Gemdosi followed by doxorubicin for PFS really did seem to do the trick. But if you look at these numbers, there's a pretty big fall off after 24 months, and the curves actually start to cross. And then interestingly enough, in this study, the overall survival benefit actually maybe favored observation. So again, for uterine confined leiomyosarcoma, we're tending to really err on the side of observation because we know most of these patients are going to likely recur, and we want to save the treatment for those patients till later on in their disease course. What about the use of anti-estrogen therapy for early stage leiomyosarcoma? Again, there's probably some potential benefit, but not nearly as much as an endometrial stromal sarcoma. Observation patients did progress more than the others, but again, this is like I said, a difficult disease to treat. Generally, we are recommending observation for early stage, certainly 1As. Again, postoperative adjuvant treatment and recommendations. Again, we do want to know the ER status and potential use of aromatase inhibitors and chemotherapy. So I wanted to talk a little bit about this, some other techniques for the adjuvant treatment of leiomyosarcoma. I hope I'm not taking the thunder away from some of our medical oncology colleagues. Alertimab plus or minus doxorubicin was tested. This study didn't quite pan out quite as well as we thought. These were patients with many different types of sarcomas, but uterine leiomyosarcomas were included in here. They looked at Olera plus doxorubicin versus doxorubicin alone. And again, it was a stratified p-value of 0.06, not quite significant, but approaching significance. So there was some thought that maybe in the overall survival data, we would see that adding alertimab with doxorubicin might be helpful. But again, that also did not pan out. So we thought that we would be proceeding with this, but this has also kind of fallen out of favor. I did want to touch a little bit on the GETIS trial because that's something that we talk a lot about in the US for treatment of leiomyosarcoma. This study actually put head-to-head doxorubicin or single agent adriamycin versus what we got out of GOG 77, which was gemdosi. It was a 1-to-1 randomization, again, across all soft tissue, many different types of soft tissue sarcomas. And what we saw is there was a very high number, probably among the largest number of leiomyosarcomas in kind of this basket trial from a pathologic standpoint. And what they did was they randomized patients to gemdosi versus doxorubicin, and they did several assessments. And interestingly enough, there was an approaching of significance with regards to progression-free survival. It did cross 1, but this did give us some pause to think that, well, certainly the toxicity profile of the doublet is going to be more than the singlet, and doxorubicin is given pretty quickly, fairly easy to give, as opposed to gemdosi, which takes a longer time and is 2 times over the course of a 28-day cycle versus just a single shot of the doxorubicin. So we thought, well, if there isn't a huge difference between these 2 groups, perhaps we should be using single agent adriamycin for patients that have leiomyosarcoma. And then when you kind of really separate it out, the curves are a little bit better, and maybe there is some benefit to it. But as you can see, probably between 36 and 48 months, the curves are starting to cross. So it did give us some pause. I think a fair number of my colleagues here in the US did have switched to single agent doxorubicin for these patients. We tend in our practice to use gemdosi, particularly for stage 2 and above, because this is just something we worry about, and maybe save the adriamycin for later, or potentially use that in conjunction with some type of anti-estrogen therapy, either with medroxyprogesterone acetate or letrozole. But again, these are difficult to treat once they recur. Unfortunately, most of these patients recur. So the summation from the surgical side, the key to these cases of sarcoma of the uterus is to get on all the tumor as best as you can. There's generally minimal lymphatic spread in these diseases. It can happen, but certainly for leiomyosarcoma, we don't generally stage them with lymph nodes. Removal of the ovaries tends to be very, very important. There is some retrospective data that in leiomyosarcoma, it may not be as important, but certainly in endometrial stromal sarcoma, removing of the ovaries is going to be incredibly important since it's such a hormonally sensitive cancer. The other thing that I want to touch on very briefly in the minute that I have left is imaging. Most common metastatic site for these tumors, particularly in LMS, is going to be the lung. So we want to make sure that we image the lungs, make sure there is no disease there. In patients that have microscopic disease to the lung, there's been some data that shows that removal of the uterus may actually help to alleviate some of the disease burden within the lung, acting as a parasitic tumor. So there's some school of thought that you should still remove the uterus even before you initiate chemotherapy. But generally, imaging of the lung is going to be very important in these patients. So that's what I have. Thank you.
Thank you, Dr. Saketh. I'm just going to invite the audience for a couple of questions. Is there anybody who wants to ask?
So the most common thing that we face is women who have undergone a laparoscopic surgery for leiomyoma, assuming leiomyoma, and it turned out to be leiomyosarcoma. and the tumor has been morcellated. So what should be the approach in this lady?
So, the black box warning has now come out of the FDA here. So uterine morcellation is pretty much over here in the US. If it has been morcellated and it comes back as a leiomyosarcoma, I would put a scope back in that patient, make sure there's no residual tumor. This has happened a few times. It hasn't happened for a few years since the FDA black box warning came out, but we were scoping those patients to make sure there was no residual pieces of tumor that were left. If there are, I would consider opening the patient to get it all out, because getting it all out is going to be very, very important in order to allow for them to have any chance at a remission or a progression-free survival. In a patient that has a morcellated leiomyosarcoma, I think most of us would give that patient adjuvant treatment with either single agent adriamycin or gemcitabine.